disappear. Okay, so thank you all for coming. Super, super excited about this topic. I guess without further ado, we'll just get right to it. This is Nate Pope. He is our brother in Utah. Why don't you tell us a little bit about yourself, Nate?
Sure. Can you all hear me okay? Thumbs up, nods head. Okay, head nods. So I have been doing OT just shy of 20 years now. I've done almost every OT setting I can think of. Not because I was dissatisfied, but because I was so interested in everything. I love kids. I love old people. I love problem solving people problems. I mean, it's just, it's a passion for me. It's the perfect fit job wise for me. So I've done a lot of things because of that. I started with pediatrics, and I'm still up to my eyeballs in pediatrics. I hear some talking in the background. Do I need to pay attention to that?
Oh, I took care of it.
Oh, okay, sorry. And let's see, along the way, well, when you work in a school district, sometimes you also end up having side jobs for various reasons. So I have always had a side job and loved working with a lot of the geriatric settings. I've done acute care, I've done skilled nursing, I've done home health. All of those have the bits and pieces that are really awesome. And I've done hippotherapy, which is now more equestrian assisted occupational therapy, is more how we refer to it mostly. And then I have done this brain recovery, concussion, traumatic brain injury, occupational therapy, what we might call either neuro occupational therapy or neurological occupational therapy. And I've kind of finally decided that is my greatest passion. So now I've created a clinic. We're shy of, let's see, 8 months now, I think, up and running. We're scheduled out about a month and a half now, and it's been going great. But I started doing the brain stuff about 6 years ago with a clinic called Cognitive FX. They are, as far as volume is concerned, they're the lead treatment center in the world right now for concussion, traumatic brain injury treatment. I was tasked with a team of therapists to help them come up with therapy to match their research. They had discovered basically that the brain was not, the traditional approaches were not very effective in doing 1 hour a week therapy. It's a little bit different than the rest of the body. 1 hour a week was just enough to overwork parts of the brain that were already compensating and overworking. And it just, people would jump to the compensatory approach prematurely. And so they had basically asked us to come up with remedial approaches to helping the brain heal, and basically gave us a week to do everything we could. This was about 5 to 6 hours a day, and we did 4 days in a row. And the results were just amazing. They initially started it thinking it would just be a test, and that they couldn't financially keep it going, but found out pretty quick that there was demand all over the world. People just desperate for help because they keep getting told this is, there's nothing else we can do. We've done all that we can do. And it's because they were just not doing it the right way. And nobody was stepping outside of first of all, what insurance companies generally pay for, which is an hour a week therapy. Now, I don't know who it is that decides that the brain is the same as everything else, but it's not. And an hour a week was not the way. The brain just doesn't respond to that sort of treatment. And so their approach was so successful that they just started growing and growing. And I was training new therapists and hiring new therapists constantly. And it was just my side job. So I was kind of going crazy at the time. But I've quickly realized it was just a therapist's dream job to see somebody on Monday go away on Friday, a completely different person, and be so many of their symptoms were reduced in such a short period of time. I knew I had to do it. So I approached the clinic, Cognitive FX, and I talked to the doctors and I said, you guys are 7 months backed up with people flying in from out of country, out of state. I want to start my own clinic. And so they gave me thumbs up. They're like not hurting for business. And they also, I think, wanted a friendly competitor versus someone else. So anyway, it's been great so far. I probably gave you more than you need to know about me. I hate talking about me, but I just love working with brain recovery stuff. And there is a totally different and new approach than what is traditionally being done out there. I'm super excited to share that with anyone who wants to hear me. So that being said, I'm not sure where you want me to start from here, Brittany. Do you have questions right off the bat? I can always start with questions, or I can tell you what our approach is.
I think starting with your approach, because like you had just talked about, like we go to compensation because that's what, typically we're taught in school and things like that, where when we had our conversation, I just was so drawn into how you had talked about, the brain compensating and then just your whole approach with that. So maybe start there.
Sure, you bet. Okay, so it kind of starts with understanding a little bit of the research and what happens with the brain. So let's just be clear, a traumatic brain injury, mild or moderate, is the same as a concussion. So they're kind of one and the same. So when we have head trauma of any sort, this is going to be my gesture. This is a healthy brain. And when your brain has trauma, there's parts of the brain that go less active. And that means they're getting less blood. You can see this in functional MRIs. That's how the research kind of began, was with a lot of functional MRIs. And there's a lot of places that can do a functional MRI, but they have not integrated the standardized battery of testing that Cognitive FX had done. And so they don't know what normal exactly should look like. In other words, they don't know exactly what areas of the brain are inactive and what abnormal looks like. So anyway, your brain, you have the concussion. Sorry, I'm trying to get in the middle of the camera here. Part of your brain goes inactive. Other parts immediately start getting more blood and compensating. And so in a normal concussion, give it a few days to a few weeks, this kind of goes back to normal. The blood readjusts, the neural pathways are still intact, and symptoms go away and you're good. And so, but there's about 20, they guess about 20 to 30% of those head injuries do not fully reset. Some of them maybe stay like this, and it becomes the brain's new norm, so to speak. So now you've got parts of the brain that if you did a functional MRI, you could very clearly see they are not getting the activity. They're not getting the blood flow during that activity. For example, you're being challenged maybe with word retrieval, or visual convergence or something. And the area that should be active is obviously getting less blood than it should. And so, and then there's always a corresponding area that is, well, not always, but most often there's a corresponding area that is hyperactive or getting more blood. So when you do an hour of therapy per week, what you're really doing is the brain is such a creature of habit, it tends to just work this harder to try to figure it out. So you're basically revving an overheating engine. And so this is why traditional approaches, they quit so easily and go to compensatory, because they realize symptoms are getting worse. If they get a little bit of progress, it's because it's learned to now compensate harder, maybe a little more effective, but they also end up with maybe headaches or some other symptom, fatigue or sensitivities to light or noise. They increase while they're improving in some ways. They're like dropping in other areas. And so what's happening is it's just working that overworking side of the brain harder and harder. So what the research has kind of shown is that if we engage the brain for many hours in a row, many days in a row, then this is not able to continue compensating, and we start seeing activation of inactive areas, and then these areas calm down and start integrating better, and symptoms start getting better really quick at that point. So we have patients, so post-concussion syndrome is what it's called. If you, and Shannon, you probably know all about that now, I'm guessing. Post-concussion syndrome is what happens. That's basically when you have symptoms that don't get better after a month or two post-head injury, you have post-concussion syndrome. And you have symptoms that range from light and noise sensitivity to headaches, to fatigue, to word retrieval issues, to both mental and physical fatigue, to blurry vision, double vision, or maybe you just don't like to do visual stuff anymore, like reading. Driving can become extremely difficult for some. Memory issues, both long and short term, but especially short term usually. Focus and attention issues, not to mention all the emotional dysregulation like depression, anxiety, irritability, brain fog. There's just so many symptoms that kind of go hand in hand with that. Balance issues, nausea, lightheadedness. The list goes on. And a lot of times someone has all of them or half of them. It just depends on each person. But when they come in the beginning of the week, they're just listing off all of these symptoms. And basically our approach is, let's take your symptoms and we're going to figure out what areas I think are inactive. We're going to give you activities we know are going to target, especially, let's say it's word retrieval. And maybe the other one is visual convergence. That's often off with concussion stuff. Visual stuff gets off. So we're going to target those two areas especially. And so we're going to try to activate them. And so we do what's called a multi-sensory integration approach. It's what we call it, because it's not just sensory integration. It's multiple sensory processing areas of the brain we are trying to engage simultaneously, so that the brain is left little option to continue to compensate and really to do the activity we're asking it to do. It almost forces it to start doing something different. The brain wants to follow two rules. Creature of habit rule, let's just keep doing what it's been doing. it also wants to follow the path of least resistance. What's the easiest? So during the week with us, we try to show it an easier, more effective way of functioning. And we give it all of these multisensory tasks. And it eventually figures out, the patients start figuring out how to do those tasks. A lot of them they feel like are going to be impossible. and they start to be able to do them gradually, and then they get better and better. And what's happening is we're starting to activate those inactive areas. And the brain is finding now an easier way to do it. It's the path least resistance rule. It's now able to follow that rule. And the only other rule we have to deal with is the creature of habit rule. And so we do it 7 hours a day for 5 days in a row. And by the end of the week, we're also mostly following the creature of habit rule. The brain has a memory for whatever reason. It still has a memory of the old ineffective way. And so we also create an aftercare program where they're going to be needing to do a little bit of therapy on their own. We go 60 to 90 days. Like, you need to do these little exercises just to keep the brain remembering this is the new way, so that it really satisfies the creature of habit rule for the brain. And then most of the research has shown that patients a year later, even with the functional MRIs, if they do their home therapy, they not only improved maybe that 75% during the week, but they continue to improve with their home program and approach much closer to the 100% recovery after a year if they do their home program. And so that's a great, I think, research and information for those who want to not lose what they've gained. The research also showed that those that did not do their home therapy, they maybe if they gained 75% during the week, they stayed pretty close to that a year later. Most of them improved slightly, like 78% or something, but they didn't improve a lot past that week. So it really also says how important doing, kind of changing your lifetime habits, which is a great place for OT to be like, let's integrate therapy into your life. Let's make it as easy as possible. I have people, they needed to balance and do and really process auditory information. So they're standing on one foot while they're brushing their teeth and they're listening to an audiobook. And they aren't taking a lot more time than what they already were doing with their morning or evening routines, but they're maybe listening to an audiobook while they're challenging their balance. And then they're visually engaged in, maybe brushing their teeth or doing makeup or something. I don't know if you can do makeup and stand on one foot, but I've never tried that one. But anyway, so OT is the perfect fit for a lot of these patients because they really need that aftercare. They need to have someone look at their life routines, hobbies, potential, things that they haven't ever started, like hobbies they're maybe interested in starting, because some people are just not active enough and they need to find some routines to start, and occupation and jobs related stuff. So we try to integrate therapy and any areas that we feel like they were not quite totally active in. We try to find a way to integrate that into their life after the week that we work with them. Okay, probably lots of questions out there now. Any questions? Maybe not.
I think you might have answered it, but I did write down one. You were saying that people in the post-concussion syndrome, that they can recover, and you do work to try and get them back to 100%.
Yeah.
My question was, can they recover? Was that the syndrome you were talking about, that they can recover back to 100%? Wow,
For
that's
sure.
great.
Totally. Yeah. Yep. We've
Cool.
seen it. Yeah. I've seen it more often than not that we recover if we're if they're engaged and if they do their aftercare. We usually get a really big jump start in that 1 week. And then if they're engaged afterwards, a lot of them get 100% recovery. We have a handful that get 100% in the 1 week, and we're like super happy about those ones. But most of them are more between, I would say between 50 and 85%, in the 1 week. And then we try to figure out what areas they need to really focus on for the next few months. And maybe, and some of the activities are more like lifetime multi-sensory activities that they need to do. I just say, just plan to do this the rest of your life. But some of those are more like hobby related, so they're not really upset about that. Usually it's something they enjoy and want to do anyway. We just have to tweak it a little bit to make it super brain healthy. So.
Could you give us some examples of those?
You bet. You bet. So if you live anywhere where there's like trails or mountains or uneven terrain even, it's amazing what the brain has to do on uneven terrain compared to walking on flat surface. It kind of can go into autopilot. You can try it yourself and close your eyes when you're walking or jogging on pavement or a sidewalk versus if you were on a trail going through the mountains. So we say, okay, uneven terrain. Let's go do trail running or hiking. I know Brittany probably supports all of this. You're going to listen to an audiobook, and something that you can't just tune in and out of. Music is a little too easy to go into autopilot with what we're listening. You're going to be like Sherlock Holmes on a trail run visually. So you're going to be intentionally looking for things in your visual environment, the leaves, the birds, the dogs, that person you just passed. Not to mention your eyes have to focus on the trail to some degree because your brain is recalibrating every so many steps. Depending on the trail and how difficult it is, it's probably every 3 to 5 steps the brain has to reprocess and know where to put your feet so you don't sprain an ankle. And so your brain has to constantly be thinking of body position like foot placement at the same time that you're making it listen to the audiobook, at the same time that you're trying to notice everything else visually. So when you get done with your trail run or your hike, you would be able to have observed and noticed and even thought about everything that you saw way more than anyone you went with, because you're intentionally trying to be engaged with what you're seeing. And you might not just see the bird, but you might think, oh, what kind of bird is that? I wonder what that bird's call sounds like. I might, you're thinking about what you're seeing. So when you get done with that, usually people are like, okay, that was, I observed so much more. It actually was really enjoyable. Like I didn't just go and zone out. I was engaged in my environment. Some people won't do the audiobook. They'll just want to listen to the environment. So they might not do anything with headphones or earbuds. They're just listening to all the sounds and thinking about what they're hearing and what they're seeing. And they're on uneven terrain, so their brain has to process that. If your brain is out of balance and you're doing an activity like that, let's say by this time they're back mostly in balance, but we need that little bit. They're not quite where they need to be because they're just a little bit, they're close. So that's the type of activity that could continue to engage those areas, because now they're active enough that they're in the loop. It's not going to be totally ignored and do this major compensation thing. Now the home therapy that you do is going to be more effective because you're mostly active and engaged, and you go for that trail run and you're doing a multi-sensory way of doing it, you're going to continue to activate and integrate. It's not just activating and getting the blood flow returned to normalcy, but it's also integrating those systems. We want vision and auditory, verbal, and vestibular and proprioceptive, and all of our higher executive functioning, all of that stuff to be integrated and not just work on them in isolation. Think of all of the therapies that we do in isolation and how much we miss out. Like if someone sits down, maybe they have speech. My son has Down syndrome. He's one of 6 kids that I have, but he's our last little guy, and he has Down syndrome. He goes to speech, but when he's there, she does a great job. But I'm telling you, it is all focused on, that verbal auditory piece, and he's not doing a lot of multisensory. There's so many therapies that are like that. We kind of like to compartmentalize too much. But what we really have found is the brain life integrates all those systems. Why should therapy be different? So when we do therapy, we try to almost always be engaged with multiple processing areas at the same time. Sorry, way long answer to that question. I think
that was great. Thank you.
Yeah, Andrea, you're on mute, I think.
Yeah, I did have a question. I don't think I was
No,
next.
Andrea, sorry. And Antonella, sorry, you're the one raising your hand. You're on mute though.
How about now? Can you hear?
Yeah.
So I have a quick question. So we're talking about during all this, the first week and also later on, we're talking about neuroplasticity. Is that what we're talking? So connection about the neurons and everything?
Yes. Yeah. And initially, remember, we have that impact. Neuroplasticity immediately kicks in. If I've got a head injury, and now, because these areas are not functioning quite right, for whatever reason, in that, when you have that impact, maybe it's inflammatory conditions, it's the acute stage of that injury, you've got areas that just start getting less blood flow. We don't know all the reasons why that exactly happens, but we know it happens from functional MRIs. So immediately other areas, this is neuroplasticity, other areas immediately kick in. But it's almost to our detriment in this case if it sticks. It's kind of awesome that the brain can do that. It is not awesome if it becomes the new norm, if that makes sense.
Okay.
Yeah, so then we're talking about neuroplasticity. When we engage here, we're trying to give it all these multi-sensory integration challenges, and it's now having to figure out how to do those, and it can't do it. In fact, we love the I can't experience over and over and over again. Like, I can't do this. And we're like, that's great. Get used to be okay with I can't, but I'm going to keep trying, because eventually that's when the brain seems to start recruiting and asking the brain to do what it hasn't been doing the last, I don't know how many years since their concussion. Now it starts activating. And so we just encourage them, like, failure over and over again, but keep trying is one of the keys. But we're going to make that neuroplasticity kick in again in their favor this time. Great question.
The majority of your patients that you work with, how long post TBI are they?
Oh, there is almost not a norm. All of our athletes usually are within 4 or 5 years to a few months. Some of them, they're like, hey, we need help now, but last week we had a college football player that was he's been dealing with this for years, and he's still been playing and didn't realize he's in post-concussion syndrome, and some of the acuteness of his injury had gone away, but he still had all these lingering issues. Anxiety and depression are things that sometimes linger. Some of the emotional stuff that you wouldn't necessarily connect to concussion. And they realized, hey, this happened. He never had any mental health issues until after his head injury. And we're like, well, that's something that maybe is unresolved. And then we found out later he also had some vision things and some other things that helped us know. But I've worked with patients, 20, 30 years post-injury and had them almost fully recover. I had a college wrestler come through that he's 35 and his last injury was when he was 18, I believe. He had like 20 concussions because of his style of attacking when he was wrestling. He would shoot with his head. And anyway, he had a complete full recovery. And that's, many years post-injury. So I try to say the earlier you get it, the better, because the brain is that whole time coming up with compensatory habits that are going to be a little more ingrained the more years go by. But it's still completely, the future still has a lot of hope for somebody, even if they've been many, many years out. So let's see. Julia, did you have a question?
So is there a point where there is a place where it's too early to start? For example, I work in acute care in the hospital. Obviously, I'm not going to be doing this with patients that are vented, but normally what we try to do with patients that have mild TBIs or concussions is we actually reduce the stimuli to allow for some healing, but that is 180 different from what you're saying. So tell me more.
Great question. So I so wish everyone had the more recent research out there. And Brittany, I'm going to send eventually all of we're still trying to get it all compiled so that you have that available to share. But there's some great folks in Canada that have done a lot of research in this area. It is the totally wrong thing to do if a patient has just had a traumatic brain injury or a concussion, to go in a dark, quiet place and get no stimulation or little stimulation and to not be active. Because what you just have said to the brain is, okay, you're in this condition now. Let's do nothing while you're in this condition to stimulate the brain. And you have just reinforced that it will much more likely, statistically, that so much more likely to turn into post-concussion syndrome if you, in the acute stage, do nothing and just destimulate. And so the general rule, and we could talk more about the acute stage, but general rule that I give, like the sports trainers, the athletic trainers in the schools and people who are asking me, is you want non-jarring cardio, especially in the 72 hours following the head trauma. Of course, it depends on the severity. If you've got brain damage and you've got a severe, not just a mild to moderate head injury, but it's more severe, then you got other things going and you maybe need to watch for some of those things. And that's where I just say, don't follow the doctor's orders on that one. Talk to your neurologist, talk to those professionals and follow their guidance. But if it's a concussion or a mild TBI, you should be doing cardio, non-jarring cardio. Like this is like a stationary bike or an elliptical or something. A treadmill wouldn't be great because you're bouncing too much. So non-jarring cardio to get blood to the brain, because that blood equals more oxygen, and all of the neuro connections we want to make or maintain or establish depend so much on oxygen being present. And so you want the like 2 or 3 times a day to do the non-jarring cardio. Then you want to engage the brain in visual and auditory and all of the other normal things that the brain does, but on a lesser degree. So that is one area that's kind of similar. We are saying stimulate it less than normal. If you're a college student, the last thing I would want you doing is studying for an exam that's really stressful. And because it could be too much for the brain to handle at that moment. But going in a dark, quiet room is definitely not what you want to do. So you want to do something kind of more on a relaxed, more of a relaxed way of doing, maybe going for a walk, going somewhere where there's visual stimulation, there's some light. You don't want to develop light sensitivity. I think some of that comes from the dark, quiet, stuff, dark rooms and also noise sensitivity. Your brain's in this really vulnerable stage, and your doctor just said, go in a dark, quiet place and don't do anything. And that is being told to everyone, everywhere. And it's not consistent with the research.
So in a way, then it's kind of like what we're supposed to do with cerebral vascular accidents or strokes, where we start treating immediately.
Yeah.
Okay.
Yeah, for sure. Yeah. And we're not challenging too much in that acute stage, but we are stimulating all the areas. So they're going to get visual. They might not be reading, studying for an exam. That's reading is a pretty demanding task. They might not be driving. That's also a very high visual demand. But they might be going for a walk, and screens aren't the best. Screens are one dimension, you're not getting the depth perception that you need. I don't think they're the best stimulation for visually. I would prefer something with, more depth to it and more dynamic stuff going on in your environment visually. But it shouldn't be overly challenging or stressful. Stress can almost act like a relapse even for some patients. We have done weeks where they had great recoveries. They weren't doing their aftercare quite right, and they maybe just jumped right back into college and studying for exam, and all of a sudden it was like they had another concussion, and the brain remembers that old way of functioning ineffectively, and they have a little relapse that way. So we really like to avoid that stuff. So after a week intensive treatment, you kind of want to ease back into things, and that's where an OT needs to also help people see the baby steps of just gradually increasing the challenge day by day, breaking it down for them. So. Anyone else?
I have a question.
Sure.
How often or do you work with other disciplines? Do you work with like speech therapists ever with these patients, or is your focus mainly OT?
Great question. So that is one of the biggest differences between us and the other leading clinic, the one I mentioned before, Cognitive FX, which we have very high regard for each other. I even met with one of the head people today, and we just went to lunch, and we have a great relationship, but we do have a difference of approach. They have what I would call a multi-sensory, a multidisciplinary team, where they that patient is going to go to something called neuromuscular and something called sensory motor therapy and something called, well, they'll go to OT and they'll have cognitive therapy, which is done by a speech therapist at their clinic. And so they have a lot of disciplines that are all coming together from different angles. I worked there for 6 years. I saw how it worked, and I actually really valued some of that multidisciplinary approach. You learn so much from each other. However, I will say the patient was going, when they went to the speech appointment, they were mostly engaged in verbal auditory stuff, and it wasn't as much of a multisensory way of doing it because the speech therapist doesn't have that background. And she's not going to make them stand on a Bosu ball while they're juggling, while they're doing the speech. And so they just had a different approach. So it was during that hour, they were mostly doing one thing at a time. And I felt like what the most progress I saw for patients when I worked there was when they were doing multiple systems engaged simultaneously. And so then I started thinking, occupational therapists are the most well-suited to do that. And so we wanted to do an occupational therapy-based clinic. So we have 2 occupational therapists and an occupational therapy assistant. And we are the heart of everything that happens here. And not a patient comes through that they don't get to know all 3 of us pretty well, and we work with them. But we're able to integrate all of that speech stuff. I'm not claiming to be a speech therapist, but none of them would feel like I was infringing because I'm not claiming it. I'm just using a lot of language, and I learned from a lot of them, but I'm doing it while I do my other stuff. And so our approach, we get to know the patient so well that the assistant that we have with us is able to adapt. And a lot of the best therapy is right on the threshold of the just right challenge. And you get to that just right challenge if you know how to grade and up and down in those baby step degrees. And we get to be able to do that so much better, what I see here, than when I was with the other clinic, just because they're going from a different person. They're going to 5 or 6 different people throughout the day. And they're all doing their own thing in a little bit different way. And it's obviously still working. They have great results as well. So I'm actually like, gosh, what's better, multisensory or having this OT based clinic? We are probably going to hire some other disciplines to come in and do a few things that we feel like, it would really be nice if we had another discipline. I really want a massage therapist, for example, to do a lot of the whiplash neck stuff. We need the blood flow going in and out of the brain, and even the lymphatic, blood, and cerebral vascular stuff, that all needs to flow really good. And it would be nice to have someone that just specialized in that for their brain breaks, because we have brain breaks. By the way, I don't know how much I mentioned that, but there's a period of time where they are overloaded. You cannot do 7 hours in a row without some brain break. It's like if you go to a conference and you feel that feeling like, I am saturated. You try to do anything else and I will not get it. And it's because that is exactly what's happening. Your brain is not ready to process more information. And so we find the right times for them to go, and we have a massage chair and a massage table. I'm also a licensed massage therapist, which I did before OT school. So I've been doing some of that and training the CODA to do some of the neck stuff as well. And she's doing great with it. So, but yeah, I think it'll become a little bit multidisciplinary, but I also think I really love having an OT based clinic because we can integrate a lot of disciplines to make it more multisensory. Good
Thank you.
question. Yeah, I get,
Sorry, another
Yeah.
random question.
yeah.
You might have already said this. How long are you with your patients each day?
You mean the set of the 7 hours?
So is it 7 hours every day or?
Every day it's 7 hours.
Okay.
The patient gets 7 hours a day for 5 days in a row.
Okay, perfect. That's exactly what I
Yeah.
wanted to know.
Yep, and that's rotating between myself, my brother, who are both neuro OTs, and our assistant.
Awesome.
Yeah,
Thank you.
yeah,
And that's when Nate and I talked about this. So Nate had a student of mine, and then I did a site visit, and then we got geeking out on neuro stuff, which then led to this, which I'm super appreciative of. But it just made me think of, one, all I learned in school was basically compensation, and I feel like maybe at least my experience of what most clinics are attempting to do seems to be compensation based. And this, I mean, my background is in constraint induced movement therapy, and this makes me think of constraint induced movement therapy for post-concussive symptoms. Whereas, it's purely remediation. And it's you, I mean, and that's the thing of like me as a practitioner, I wouldn't know what to do as far as how to design my interventions and whatnot. And so you've given us some insights as far as the multisensory input. But I mean, I think that's the thing of like, you have dug into the research and have experience, and then obviously now anecdotal, and then your own research and things like that, where I think that's the ticket here, where I think there needs to be more of that, because it seems like Streamline OT is going towards compensation, because maybe it's not so prevalent on what can we do as maybe general practitioners for remediation. And hopefully future research that comes out will make maybe a paradigm shift that more OTs as general practitioners and just general academia are learning remediation as well as compensation. Do you have any thoughts on that?
yeah. So there's always a time to compensate, but it never should precede remediation. So in my opinion, I mean, none of us, if we're like have any issues, we want them fixed first, if possible. Can I recover? That needs to and should be the number one. Any true therapist at heart, in my opinion, really wants that. We want you to fully recover and we want your brain, in this case, to do what it's supposed to do. And if there's a way to help it do that, if you're light sensitive, I am not going to give you sunglasses. If you have a headache, I do not want you to become dependent on headache medication, especially if it just came after your head injury. If you all of a sudden have anxiety and depression or ADD or ADHD, I don't want you to jump into those medications for all of those things, because the cause was you hit your head. I will tell you, we have had so many patients who are on those medications, and we just say, let's see what we can do. If we can get your brain to remediate, we want to recover and then let's see what cards you've been dealt after that's done. And that's when compensation is just awesome. There is a time and a place, and we are the OTs we're the people who can help them. And it's so satisfying sometimes to give someone what they need, and even in the form of compensation. But it should never be the first thing. It should always be after we've remediated everything we can remediate, in my opinion. Shannon, your mic's off. Did you want to talk?
My mic is off.
Yeah, I wondered if you were wanting to say something.
Oh, no, my husband's been listening and he is just like, we need to get you down there.
Yeah. Yeah, I will say we start with a free consultation because we want as much to have it be a good fit for the patient. We want it to be a good fit for us. We want to take patients we feel like we're sure we can help. It's in everyone's best interest that way. So I give so much free advice. I have so many people coming in and doing a free consult. And I love referring out. If I'm like, I don't know if I can help, this is not, I have a patient that came in today who has severe depression and moderate anxiety, but had no head injury. And they heard of us and wanted me to see if we could help. And, I had to say, I don't know if it will help you. They did do a pool of research when I was at Cognitive of all the patients that had not been concussed and their improvement curve. So the patients that were concussion, it was pretty steep. They started here and ended up here, sorry. And all of the other patients they put in a research pool and their improvement was like this. They all still improved quite a bit. So we were like, oh, this intensive way of working with the brain is actually able to help many other things, not just post-concussion syndrome. And so we kind of got excited about that. But yeah, Shannon, you can come bring your husband. I don't know if you're in Idaho, if you want to drive down, but we also do Zoom consults for all the time. So
He's edging over.
hey, how's it going?
You snuck in.
Yeah.
He's
no
not
worries.
an OT. Everyone here is an OT or student.
No, you're welcome.
Yeah, the intensity is great. And I have to say, none of the doctors here were pro, stay in a dark place and don't do anything. And of course, I'm an OT, so I tried to OT myself a ton and enlisted some of my coworkers like Andrea. But and I'm still doing my own therapy. But I did. It took a little time because they were more conservative, and you said it depends on the intensity. So they were more conservative at first, and but I did take walks as soon as I could walk, and things like that. And I did hear after my first year, my rehab doctor told me, oh yeah, it's great that you're going for walks, but I was only going on paved trails because of the balance and all the stuff visual. He's like, yeah, you need to get on uneven surfaces and get out and hike. So that was something that rang true. I was like, oh yeah. But the doctors here have been good, but it's definitely it's not the intensity anymore. Everyone seems to be jumping into that compensatory place, and I'm not at that compensatory place.
Yeah. It's the system, it wants to do what has traditionally been done, in large part because of insurance, but there's other reasons too. And it's just clinics are almost set up for, and their schedules and everything is set up to function on an appointment by appointment basis, and doing 7 hours in a row, that for 5 days in a row, they would have to redo the way they do everything. And so not a lot of clinics are ready to just do that, even if they suspect it might be, helpful. But most of them just don't know. They don't know that the level intensity needs to be multiplied by quite a bit. And then you could get so much more done in 1 week than a whole year or many years worth of 1 hour a week therapy. We often are getting patients who have already done that. because they want to do all the insurance options first. So a good part of our patients have already experimented with the 1 hour a week. They're like, I've been here and I've been here. I've worked with patients who've been at the Mayo Clinic and turned away. Like, we've done everything we can. Even told, if we can't help you, probably nobody can. But nobody had done an intensive program with them because they just are not out there. And so it's just the way the brain heals. You know, Dr. Norman Doidge is a great, you know, The Brain That Heals Itself is a great book. A lot of what, you know, he was kind of the neuroplasticity guy, and would just go around the whole world traveling, trying to find people who were doing things that worked. And he started putting a lot of little things together. A lot of what we do is also based off of some of what he discovered as well. But you know, it's definitely not the traditional approach. But you know, people are starting to become dissatisfied with insurance these days, and are more willing to recognize that, you know, maybe out of pocket, or if they have an HSA, or, you know, there's other options. We've tried to make it more affordable. If you want to know costs, the competitor that we work together with, Cognitive, they do a functional MRI, and we don't, but we can refer you to them to get the scan if you want the scan. We've kind of worked out a way to collaborate in that way. Their program is now $13,000 for the 1 week, and ours is $6,000. So they do 25 hours of therapy and we do 35 hours. So we're more robust on the therapy side of things, and they're definitely more on the functional MRI diagnostic side of things. I worked enough with the functional MRIs that I'm pretty comfortable getting a symptomatic evaluation, the patient telling me all of the areas of what's going on, and then I do some performance testing with balance and vision and some other things. And at the end of that, when I worked with the other clinic, I kind of would think, okay, I think I know what your scan's going to look like. Let's look at your scan. And it was usually what I was thinking it would look like. So at that point, I realized I could do and be very effective with a symptomatic approach. So that's kind of where we do that. But I don't discourage anybody who wants to get the functional MRI to not get it, because it's added valuable information to confirm. So. Hey, Derek.
Hey, Nate, how are you?
Good. Let me introduce all of you to Derek Bodden. He was a colleague of mine over here in Utah and then went to Idaho, of all places. He is in Boise area right now and starting his own clinic. I'm half trying to talk him into doing a little brain clinic over there in Idaho. So.
Thank you.
There you go. You've been introduced. He's awesome.
Appreciate it, Nate.
Yeah.
Where do you work now, Derek? Or do you have your own clinic?
I am right now just independent contractor. I just work for myself, no clinic as of yet, and just kind of starting to grow things and working towards that. So
That's cool. I know when Nate and I were chatting, it's, you know, like Idaho, obviously, I mean, there's room for this type of treatment all over the place. And neuro is my baby. And that's where I feel like, you know, I would love to see somebody partner up with Nate and let's get a satellite clinic here going somewhere in Idaho. Boise obviously makes sense. Eastern Idaho, Lisa Hong makes sense because you're not busy enough. You know, but I mean, I just love this idea because it's if I had a concussion or I had something, I would totally not be telling, like, you can go take that, whatever compensatory stuff, shove it somewhere else. And I'm going to find someone that's going to fix what's going on. And that makes sense. But as an OT practitioner, if someone told me that, I wouldn't know what to do. And I think that's obviously the problem. That's the thing that maybe your clinic is just, well, maybe you want to keep those secrets to yourself, but I mean, that's what your clinic is doing. And that's a special thing for our patients that need those services. So that's pretty awesome.
Yeah, we realized our approach is pretty different from the other clinic that I started with, because I think they're kind of becoming a hub for a lot of international people flying in from out of country. They have a lot of means. It's, pretty expensive. And so and we realized there are way too many people for this to be in one location, and make everybody fly from all over the world to come to them. And so it kind of works out because our approach is different. So we work well together that way. But our approach really is, we're going to get this clinic exactly where we want it, hopefully sooner rather than later. We're on track so far. And then we're thinking maybe another one in northern Utah. And then we're thinking Idaho and Colorado, just kind of surrounding, and then just kind of see where it goes. So anyway, yeah, so who knows? I might be working with some of you someday.
I have a question. Can you hear me?
Yeah.
All right. So these are specific to your clinic, but so how many clients can you see in 1 week then at your clinic?
So our clinic, just space-wise and due to the nature of the multi-sensory tasks, I mean, for example, we had college soccer player here. We set up an obstacle course where she could dribble with the soccer ball all throughout while we're doing word tasks and challenges with her, but she used the whole clinic all by herself. It was like, so right now we could probably do 3 at a time, and that would be our max. And then I would have to get a new facility. And so, but remember, one patient in a model like this, where it's 7 hours a day for 5 days in a row, is the equivalent to 35 patient hours. So that's like 35 patients. Think of the scheduling and all of the logistics of arranging for 35 patients 1 hour visits. I'm just talking like the attractiveness of the model compared to one patient being that same amount of hours and compensation. So that's where it's a totally different model, but I think it's a really good one. So yeah, right now we're doing 1 to 2 patients max at a time.
And then I remember you saying in the beginning how long your clinic has been there, but I can't remember. Was it just a few months that you've been going, or a few years now?
I think we're almost 8 months.
8 months, okay.
Yep. This will be coming up on my 7th year doing this, if you include the time I spent with the other clinic. But for my clinic here, it's just been about 7 months.
And then, sorry, last question. You said that you are a neuro OT. So does that come because of like different continuing education courses you've taken? So you've like earned that title, or just from your experience at the other clinic, you are now a neuro OT?
Yeah, it's not neuro OT or neurological OT is more a description of. It's like a pediatric OT is an OT that works with kids. So there's not like a special certification. I didn't go to a certain program that was all about the neuro or anything like that. Yeah.
Most of them are first year courses.
Man, you guys are patient. You probably thought you were here for an hour and we're past that. So. I'm good with whatever time though, Brittany, but you just let me know.
Yeah, so I'll just add, I put in the chat my email address. So Nate and I will be in contact, 'cause I know they have some developing resources, but he has some other resources. So as I get more, I can certainly distribute out to those that are interested. And then certainly there's some new faces on here where if you're not on, I send out a monthly email about Journal Club. So if you want to be included on my monthly kind of listserv distribution on what the topic is and what the date is and the time for this Journal Club, I would love to have you guys. So please put your emails in the chat if you're not on there. Yeah, I just think this is fantastic. And maybe Nate, we could work on, like, if there is some existing research that could help guide OT practitioners on some of those remediation techniques, that would be pretty awesome. But we can kind of work that out. But I just want to extend a huge thank you again for sharing your expertise and just, I mean, talking about this topic that is so prevalent. And again, I mean, I look back at my clinical experience where OT was brought on for compensation and speech therapy did all of the, you know, I mean, I guess they mainly just did cognitive testing for these clients where it's like, who was doing remediation and why were the speech therapists, you know, and I loved my speech therapist friends, you know, so it's not that fighting head turf war type thing, but I mean, we had that where they were so booked with the concussion patients and OT was kind of sitting here like, we could do more, you know, and then it's, you know, here it's like, you've opened our eyes to, we could be the main contributors. We are best suited for remediating this population. And that's what I would want if I was a patient. So I just think that this is really, really exciting and what you're doing is amazing. So thank you for sharing your knowledge with us.
Yeah. Thank you guys. You guys are awesome.
Okay, we'll see you guys later. Yeah, and then I also put Nate's website in the chat. And I guess, Nate, you could put your email in the chat if you would like to.
Okay. Sounds good.
Stop.